Ready? Okay. Good afternoon. As Lily said, my name is Connie Mobley, and I'm going to finish up this afternoon by talking to you about nutrition and aging. In looking at some of the slides that Dr. Saunders was showing, it came to my mind that without good oral or dental health, it doesn't much matter what people eat, because obviously they can't eat with those kinds of problems. So hopefully those issues can be addressed so that people can eat appropriately. There are a lot of unanswered questions about nutrition and aging, but we are beginning to answer some of those questions, and we're beginning to find that as people age, they have some very unique needs. So in the time that I have with you this afternoon, I'm going to try to address some of those specific issues and why they exist, and then talk a little bit about some of the screening tools that are available to people who are in healthcare that they can use to assess where people are, and then lastly give you just some key messages that you can take home with you and hopefully use with your patients and the people that you care for. So my overall goal is really twofold. What I want to do is discuss the need for dietary counseling and talk about the recognition that age may actually alter people's nutritional needs and may actually alter the management of patients. I often ask healthcare providers if they ask their patients about what they eat, and I don't always get the response I want. So hopefully after you hear this afternoon, it will remind you to ask that question, because frequently they won't tell you what they eat unless you ask. And it's very telling sometimes about their health in general. So what I'm going to do is I've identified 10 possible changes that occur in the aging process and what that means in terms of people's specific nutritional requirements. And these are on the handout that you've received for this particular lecture. The first thing that I want to bring up is that there is a change in muscle mass. As people grow older, their muscle composition decreases, and in parallel with that, their fat mass increases. So from a nutritional perspective, that basically means that their calorie intake is going to have to decrease, and their protein intake, however, is going to have to either maintain itself or possibly increase. And that is because as people age, the metabolism and function of the whole metabolic processes are slowed down, just as other things in aging are. And so the requirements for protein are slightly elevated. And you can see this in relation to some of the other issues that I'm going to bring up. These are some data that were recently published a couple of months ago illustrating some of the National Health and Nutrition Examination Survey data from 1988 to 1994. And what I want you to look at is the trend in terms of BMI, or what is body mass index, and TSF, which is the Tricep Skinfold, in both males and females at various decades of their life from age 50 and beyond. And if you look at the trends in terms of the direction, the drop in the various levels of the graph, you'll notice that with aging, body mass index declines, and what that means is people actually begin to lose weight with aging. Body mass index is a ratio of height to weight, and tricep skinfolds actually illustrate the degree of fat mass, and interestingly enough, the fat mass declines as well as does the muscle mass. And you can see this particularly, it's particularly striking in females as opposed to males. So the body mass index is illustrating weight in kilograms divided by height in meters squared. And in the healthcare arena today, body mass index is considered more or less the gold standard for monitoring people's weight and change in weight. And when we look at Tricep Skinfold, what we're looking at is the Skinfold measure at the mid-arm circumference, and we measure this with Skinfold calipers. So again, if you look back at that particular graph, you can see those declines in both body mass index and Tricep Skinfolds. So there is definitely a change in body composition as we age. Now, this caloric decline, or this need for caloric decline, is related to a number of things. One is this loss of lean body mass, because we know that muscle mass is more metabolically active tissue than is fat mass. Also, people as they age have low energy expenditure. They tend not to be as active as they were when they were younger. And there's also a possible decrease in glucose tolerance as we age. People are actually more susceptible to developing impaired glucose tolerance with aging. So all of these things relate to the need to decrease calorie intake, but at the same time to increase protein intake. So what we need to encourage elderly people to do is to include in their diet sources of meat and poultry, fish and eggs, dried beans, soy products, milk products, and nuts, and that should be seeds. And then along with that, to include whole grains, which are going to provide them with fiber and other source of calories that do also provide some protein, not to the extent that the more high-quality proteins would, but some protein. So we'd want to encourage elderly to include these in their diet. Now, another major change that occurs in aging has to do with a decrease in bone density. And this decrease in bone density demands that we likewise increase our calcium intake and vitamin D intake. And so we now recommend in general for men and women over the age of 50 that the calcium intake be at 1,300 milligrams per day. Now, the recommended dietary allowances are lower than this. The new dietary reference intakes have been set at 1,300 milligrams across the board for both men and for women, and for younger adults and older adults. And so when you translate that into something that's applicable, it means drinking 4 glasses of milk a day. And just to give you a sense of comparison, a cup of yogurt has about 400 milligrams. A cup of broccoli has about 80 milligrams. So it's not very likely that a person who is not including dairy products in their diet is going to get enough calcium from diet alone. And oftentimes, as people age, they sometimes develop an intolerance for either the protein in dairy products or a lactose intolerance. And so this is a particular nutrient, calcium in particular, along with vitamin D, that we may need to consider for supplementation in older age groups. Another change is a decreased sense of taste and smell. And this is probably more striking with the smell than it is with the taste. However, these things go together. The way food smells affects how good it tastes. So it may be that as people grow older, those who are providing care for them or who are overseeing their intake want to pay particular attention to the types of foods that they eat, to how those foods are prepared, and to how they are presented. We know that as people grow older, sometimes they tend to skip meals, sometimes they tend to forget to eat, and we need to pay attention to how food is actually presented to them. And that sounds so simple, but it is really quite important, particularly for those elderly people who are living alone. Another change is that there is frequently a decrease in saliva production and there's loss of teeth, and Dr. Saunders covered that very, very nicely in her presentation. Because of this decrease in saliva production, that increases a person's risk for decay or caries and loss of teeth. So by encouraging the elderly to consume adequate amounts of water and fruits and vegetables, we can appropriately address that particular change. An additional change is an increase in gastric pH. Now, this increase in gastric pH will affect the absorption rate and utilization of some very specific vitamins and minerals. So what this means for people as they age is they may actually need larger amounts of particular vitamins and minerals than they did in younger years when they did not have this increased gastric pH. So it's becoming pretty routine to recommend increased intake of vitamin B12 and folic acid for the elderly person because both of these vitamins are directly impacted. The absorption of these vitamins are impacted by gastric pH. And then the minerals that are specifically affected are calcium and zinc. So as people age, they need to increase their intake of food sources of these particular vitamins and minerals or possibly consider supplementation. B12 is going to be derived particularly from animal products and other animal sources like meats and dairy products. And folic acid is going to be found most prevalently in fruits and vegetables. So the message is again the same, increasing animal products in the diet as well as fruits and vegetables and grains. One particular thing I'd like to point out to you is that sometimes when people eliminate red meat from their diet completely, and they may do this because of their concern for changes in their lipid profiles, they often significantly decrease their intake of zinc, because one of the very best dietary sources of zinc in the diet is red meat. And so that's something to bear in mind in terms of making specific recommendations to the elderly. There's also a decrease in hepatic uptake of retinol. So in this instance, people will need less vitamin A. We've been talking to this point about their need for more of particular nutrients, but in the case of vitamin A, elderly people may need maybe not more than they had when they were younger, or possibly even less, and it has to do with the hepatic uptake of that particular nutrient. There's also increased levels of homocysteine in elderly, and increased levels of homocysteine have been associated with increased risk for cardiovascular disease. We do know that adequate to high intakes of folic acid, vitamin B6, and vitamin B12 can help to decrease homocysteine levels. So as people age, again, they need to include dietary sources of these particular vitamins. Then there's a possibility for decreased immune function, and again there are some very specific vitamins, and you can see here a pattern that the same ones are kind of popping up each time. Vitamin B6 is popping up again, zinc is popping up again, and here we see vitamin E. So there's a trend here in that as people grow older, they may need less calories, but they need more other nutrients, which means that what they do eat needs to be more nutrient dense. There's also an increased oxidative stress status that occurs as people age, and in fact, oxidative stress has been associated with aging. And we know that there are some specific vitamins and some of what we call non-nutrients or phytochemicals that can actually act to improve this increased oxidative stress status. In other words, they act as antioxidants and can counteract the effect of that. Now, the best sources of these particular nutrients, if you look at the antioxidants, are going to be fruits and vegetables. And so that message again comes up about more fruits and vegetables and whole grains being important in the diet. And finally, the last thing is this increased risk for dehydration. We frequently find that as people age, they may not respond to the sensors for thirst and may not drink as much water as they should. I frequently work with patients who don't drink any water. They drink only coffee or tea or soda and forget to drink water altogether. Interestingly enough, there was a recent publication that came out that illustrated a food guide pyramid for the elderly, and it specifically included the 8 glasses of water per day on that pyramid to specifically address this increased risk for dehydration. That can either occur with lack of response to thirst. Frequently these people may be on multiple medication which may affect water balance, and they are just more susceptible to dehydration. So this increased need for water is quite significant. I'm going to turn this on and just point out the food guide pyramid for the elderly, and if we can get that up on the screen, you'll see that it's not much different from what we recommend for the general population in terms of the food groups. And all of the things I've mentioned are well illustrated in the food guide pyramid. And you'll see here down at the bottom the water that I was talking about. This is such a simple model or template for good nutrition. And it's applicable not only for the elderly person who is healthy, but also for the elderly person who may be managing diabetes or heart disease or cancer or any other medical condition, because this illustration basically professes that the diet should be low in fat, higher in protein and lower in calories, and be based on a diet that's significantly adequate in fruits and vegetables and grains. And that message is kind of universal across the board. So the take-home message is that age-related changes in body composition and physiological function are going to influence nutrient requirements as people age. And we need to address these in caring for the elderly and in trying to prevent their risk or decrease their risk for other chronic or associated diseases. Now, I want to switch now to talking about how we can go about screening the elderly in terms of their nutritional risk. And probably the simplest, the most time efficient, and the most readily accessible screening tool is the National Nutrition Screening Initiative tool. This tool was put together by a number of agencies approximately 10 years ago, and it was designed to actually highlight the warning signs for nutritional risk. It was also designed to help people identify when an individual needed additional assessment or referral, and in addition to that, it was designed to be very brief, very simple, and very generic. We use it here in the dental clinic at the dental school, and it's quite interesting how it correlates highly with some of the food records that some of our patients keep. Generally, their responses to this particular screening initiative parallels what they say they eat on a day-to-day basis. So it serves a very useful purpose. Can we put this back on again, Jeff? Okay. Now, you don't have a copy of the screening initiative tool, but I think in the references I did indicate where you can order this, and how it might be available to you. It's basically a series of 10 very simple statements. And these 10 statements have been identified as being critical and important to identifying who is at nutritional risk. The very first statement is, I have an illness or a condition that made me change the kind and or the amount of food that I eat. We know that 4 out of 5 adults have a chronic disease that affects the way they eat. So by asking this particular question, we're identifying what might be putting them at nutritional risk. The second question statement says, I eat fewer than 2 meals per day. The one after that says, I eat few fruits or vegetables or milk products. And the one after that, I have 3 or more drinks of beer, liquor, or wine almost every day. These are all statements designed to identify those people who are eating poorly. They're either eating too little or too much, or they're making the wrong kinds of food choices, or they're drinking alcohol in excess. These are all key indicators of the nutritional status of an elderly person. The next statement has to do with dental health. I have tooth or mouth problems that make it hard for me to eat. Undoubtedly, if you don't have teeth, or if you're having difficulty, or if you have lesions in your mouth similar to the ones that Dr. Saunders showed you, you're not going to be able to eat adequately or to choose a variety of foods that are going to be beneficial to you or that are going to respond to some of those physiological changes that occur with aging. The next statement says, I don't always have enough money to buy the food I need to eat. And that refers to economic hardship. As many as 40% of older Americans have an income of less than $6,000 a year. And they spend only about $25 a week on food. And in today's market, $25 might buy you 1 bag of groceries. So being in an economically disadvantaged situation puts a person at nutritional risk and is something that needs to be explored. This next one is very important. I eat alone most of the time. We have data that shows that people who are married and live with their spouse and eat with their spouse eat much better than people who are alone or who are single. And this is even more so true among the elderly. When they live alone, they tend to not eat at all, or they tend to limit what they eat to maybe one, two, or three things. I recently visited an elderly woman who lives alone, and all she had in her cupboards was Oreo cookies, and she had chocolate ice cream in her freezer, and that's what she was living on. So it can be as simple as that in terms of increasing risk for nutritional deficiency. And in fact, she had ulcers. She had decubitus ulcers that were not healing. And this was actually directly related to the fact that she was eating a diet that was inadequate. The next one speaks to taking prescribed or over-the-counter drugs. Anyone in this room right now have a guess at what percentage of elderly people are taking a prescribed or over-the-counter drug? 85%? 90%. So that's pretty significant. And if people are taking drugs to that extent, this is going to either increase or decrease their appetite. It can change the way things taste. It can make them weak. It can make them nauseous. Some drugs constipate them. All of these things have an effect on their nutritional status. The next one talks about an involuntary weight gain. They have either gained or lost weight, and we use 10 pounds in either direction in the last 6 months. We know that, in fact, change in weight, if there was only one thing that we could monitor to determine a person's nutritional status or nutritional risk, it would be change in weight. And so this is a truly good indicator of one's risk. And then the last one talks about being physically able to shop and cook and actually feed themselves. And we know that probably 1 out of every 5 people, elderly person, has trouble either walking or shopping or buying and cooking food. So these 10 different statements, if you get a simple response to them, can help you to categorize a person as either being at good or moderate or high nutritional risk. And then beyond that, if they are at moderate or high risk, this particular module, which is available, this nutrition screening initiative, then makes suggestions as to who this person should be referred to for additional assessment, or who they should be referred to for additional care. And some of the additional assessment has to do with looking at additional anthropometric measurements, looking at mid-arm circumference, and the biochemical data that's used as markers have to do with using the serum albumin and the lipid profiles. We know that in the elderly, for instance, if their serum cholesterol is below 150 milligrams, then they are at nutritional risk. We're frequently worried about everyone's cholesterol being too high, but in the elderly, it can just as well be too low. So this is a very good reference for you if you're looking for something that is simple and easy to use as a screening tool. That also gives you some direction in terms of where to go with this information should you identify people who are at risk. So the take-home message here is that nutrition screening will identify nutritional risk, and it really should be part of the routine assessment and monitoring of elderly adults' needs. If there's not time for the 10 statements, simply asking them what they're eating and how frequently they're eating can give you quite a bit of information. Now, there's some key nutrition messages that I'm going to try to leave you with. I don't want to keep you past 5 o'clock. But the very first one is you should encourage elderly people to know how much and what foods are beneficial because they are older, and what are their nutrition needs, why their nutrition needs may be different, or they may be changed because they're older. Frequently in talking to older people and to the elderly, I find that they're not always aware that their needs are different. And when they realize this, they're quite anxious to make the necessary changes to address that. Also encouraging them to achieve and maintain a healthy weight, and oftentimes it's weight gain, not always weight loss, that's important with this particular group of people. Also, they should learn how diet will play a role in health maintenance and disease treatment. We have excellent data, for instance, that shows that hypertension can be very well controlled with a good diet and with good weight management. And given the choice between multiple medication and diet and exercise, some elderly people will prefer to actually change their diet and make those necessary changes because there are no side effects with diet and exercise like there may be with medication. We should also encourage them to use the food guide pyramid and the dietary guidelines and to stress variety of foods. A good rule of thumb is a person should be eating at least 10 different kinds of foods a day. If they're eating 10 different kinds of foods a day, they're probably getting enough variety. Also, they should choose nutrient-dense food. Now, what that essentially means is looking for a food that will give them the most bang for the buck. So they're looking for something that will not only provide them with calories, but also provide them with vitamins, minerals, fiber, and phytochemicals. And those are generally going to be whole-grained and unprocessed foods. Those foods are likely going to provide them with the most nutrient-dense source of nutrition. And then you can't skip exercise. That's important, particularly given that there is this tendency to have decreased muscle mass. There's good data to show that strength training can stabilize muscle mass and in some cases improve it. And in that case, it reflects on nutrition because if there's more muscle mass, there's potential to consume a higher amount of calories, and it also improves appetite as well. Also, they should be encouraged to ask questions of their healthcare provider about nutrition, to ask the questions that they have that concern them. When it comes to supplements, there are some key kinds of things to keep in mind. Supplements are definitely with us. They're an unregulated industry, however, and we should encourage the elderly to approach the use of supplements with some caution. So there's some simple guidelines that can be promoted among the elderly. First is that they should read the labels very carefully. They should follow the directions that come with supplements. Supplements are just like medication. They were never intended to be taken infinitum. They were never intended to be taken in very large or massive amounts. And there are directions that come with them, and they should be encouraged to follow them. And then they should also be encouraged to share with their physician or their healthcare provider what they are taking, what quantities they are taking, and what the source of those particular dietary supplements might be. The bottom line is that we need to encourage the elderly to first eat a low-fat diet and eat adequate protein, eat 5 to 9 fruits and vegetables per day, and this is a little bit more than what we tell the public at large, and this of course comes from the more recent very outstanding hypertension studies that showed that individuals who ate 5 to 9 fruits and vegetables per day had much better control of blood pressure. Also to eat foods rich in calcium because of the loss in bone density. The take-home message is that the elderly can meet their nutritional needs with an adequate diet, but we do know that supplements are important for this group, so supplementation should be encouraged, and it may actually be necessary for some, and we're finding that to be more and more the case with calcium and vitamin D supplementation in particular. So with that, I'll stop, and it's 5 minutes to 5. Should anyone have any questions? Be happy to answer them.
What is your take about elderly people liking a lot of starches and sweets? Have there been any studies about those? It seems to me that they prefer quite a bit of sweets and starchy food. I don't know because it's easier for them to digest or because it's less expensive or who knows?
Well, sometimes I think it may be that it's easier for them to digest. It may be easier for them to chew. One of the things we're finding at one of the studies we have ongoing here at the school is that there is loss of muscle strength in masseter muscle, which is the muscle that's involved in chewing. And that we find that as people grow older, they prefer not to have to chew for a very long time. So they may choose to eat things that are softer and easier for them to manage. But oftentimes, if you point out to them that, for instance, there are a lot of fruits that are very sweet, and that if they do desire something sweet, that if they chose that more frequently, they'd find that they could satisfy that need to eat something sweet And then they'd also get the benefit of the additional nutrients. Any other questions? Any questions from any of the sites? If there's anyone still there.
I just wanted to make an observation that regarding eating, it's very confusing because the messages are in a language that nobody understands. Even we physicians or care or health professionals, when they say that we should eat 30% of the calories should come from fat.
Mm-hmm.
Yeah, that's nice. How do you do it? Take, like you say, take nutrients, dense nutrients, or what have you. Well, most people, they don't know anything about the things.
Right.
Even the labeling of the food is very confusing. There was a doctor in Washington who is a pediatrician, a PhD, Dr. Kessler, who did a lot of legislation, or rather implemented a lot of changes regarding food labeling. And it was better, but now you see a bunch of sweets and they say fat-free. Well, it's sweets, so it shouldn't have any fat, but I mean, it's very deceptive. The food industry regarding selling food for everybody. So it's quite difficult.
You're absolutely right. And if there's any one message, somebody said to me, can you give me one message? I usually give them the eat 10 different foods a day. If you're eating 10 different kinds of foods a day, you're going to eat a variety, and you're likely to choose some of those things that are more nutrient dense if you're choosing 10 than if you're only choosing 3 or 4. And so that's just one rule I usually give to people. The other is that if they're eating a variety of foods, they're likely going to be getting enough protein. The fat issue, I think, in terms of, from a nutritionist perspective, is actually a debatable one right now. I'm not sure we know how much fat is enough fat or how much is too much fat. And I think you're going to see some things coming out about that, even more so than you have just recently. It's probably more so has to do with the type of fat than the amount of fat that people are eating. That's the issue.
Yeah, the pyramid of food, it seems to me that there's too many starches at the bottom. I mean, the main, basically, most of the food is starchy type of thing. It seems to me that it's too much.
Well, it's starchy if you choose processed foods, but if you choose the whole grains and the fresh fruits and vegetables, it's not. So I think that's the message that people haven't gotten. They've thought about it in terms of pasta and rice, and not in terms of whole grains and fresh fruits and vegetables. But I think if you put the fresh fruits and vegetables in there and you put the whole grains in there, you'd find that the starch content is probably not that high. But the fiber content would be very high.
Thank you so much.
You're welcome. I didn't want to go beyond.